amazing opportunity. It's truly an honor to be presenting about a topic that we all feel so strongly about. I'm just going to share my screen and start the presentation. Okay, so basically, human trafficking is something that we weren't very well versed with when we started residency. And it all started because me and a few of my colleagues, we came across a few patients in the emergency room, and we felt like their stories were just not adding up. So when we spoke to each other about it, we researched a little bit more about human trafficking, and we realized that these patients could have possibly been trafficked. A little bit of a background, we work in a hospital called Maimonides Medical Center, which is in Brooklyn. It's a very diverse patient population. So we're basically located between Chinatown, a large Hispanic population, and a large Orthodox Jewish population. So these populations are already marginalized and more vulnerable. So we see relatively higher numbers of trafficked patients. So before I get into it, just want to outline the objectives of this project. Basically, it would be to define human trafficking, understand the types of trafficking, recognize red flags for both sex and labor trafficking, identify the common industries, understand screening for victims and the importance of having a hospital protocol, and implementing a trauma-informed care. So what is human trafficking? There are lots of really complicated definitions about what this is, but it's basically the business of stealing freedom for profit by use of force, fraud, or coercion. When we think of human trafficking, we think of smuggling of people across international borders or kidnapping, but that's not all it is. And I think we just want to highlight that human trafficking can affect anybody. Anybody can be a victim. And in the next few slides, we're just going to show you the different demographics that victims can be of. It can come in any form of exploitation, including stripping, domestic servitude, camming. And I want to stress again that anyone can be a victim regardless of race, gender, or immigration status. When we get down to the technical definition, this is more a US-based definition, but the only difference between US and Europe is that in the US, only sex and labor are considered forms of trafficking, but in Europe, it's sex, labor, and organ trafficking. We haven't had too much exposure to organ trafficking, so this presentation is going to focus more on sex and labor, but just to highlight that Europe includes organ trafficking as well. Yeah, so basically what happens is there's an action, right? You recruit, harbor, transport, or obtain people for a purpose of sex or labor. And the means can be force, fraud, or coercion. It doesn't have to necessarily be just taking somebody completely against their will. It could even be by fraud. Like, for example, you could tell somebody you're going to get them a job, and when they actually move to a different country, you do give them a job, but you don't pay them as much as you told them you would pay them, or you kind of extort resources from them in the form of their work. With regards to minors, even if they voluntarily get involved in sex trafficking, that is considered human trafficking if they're below the age of 18. Just want to highlight the worldwide prevalence. Like I said, there's not a lot of awareness amongst healthcare providers. And I just want to highlight that, it's a 20.9 million victims worldwide, which is very, very, very underreported because most victims are vulnerable, as a result of which they don't come out and they don't share their experiences. But you can just take a look that these victims are spread throughout the world. It's also a multi-billion-dollar industry. When we think of trafficking, again, our mind immediately goes to sex trafficking. But again, just want to focus on how human trafficking can be many different forms. And if you look at the worldwide statistics, 46% of it is sex trafficking, but the majority of it is actually labor trafficking, like servitude, working in farms, working in factories, etc. If we look at Europe in particular, you can just see the different types of demographics that it affects. 56% of the victims in Europe were used for sexual exploitation, which is a little different from worldwide statistics. If you look at the world, it's more labor trafficking than sex. But if you look more at Europe, it's more sex than labor. It's very similar statistics in the US as well, where most victims are used for sex trafficking and fewer for labor trafficking. If you look at the trafficker sex ratio, you notice that there are more males who are the perpetrators of trafficking, whereas the victims are mostly females. And if you just take a closer look at the victim citizenship status, you can see that both EU citizens and non-EU citizens are affected by this. However, if you look closer at the trafficker citizenship status, you see that it's more EU citizens than non-EU citizens. So keeping all this in mind, human trafficking, we just want to take a closer look from a healthcare provider perspective. So why is it important for us as doctors and healthcare providers to understand what human trafficking is? So historically, human trafficking was taken from a more punitive standpoint, where there were laws and legislations in place to punish the trafficker. But what happened was that these traffickers found different ways to exploit victims. So with the advent of the internet, they found Craigslist or online forums where they could traffic victims. So this wasn't a very useful, it's not very useful to punish the trafficker. It's more useful to provide resources for the victim to empower them and get them out of their position. So healthcare providers actually encounter a lot of victims of human trafficking. It's just that we're not well equipped to identify them. A lot of studies have shown that around 80 to 90% of victims have encountered a healthcare provider in the process of being trafficked. And this is like in the ER, their primary care physician, their psychiatrist, their OBGYN. And the reasons for that are varied, and we'll talk about that more in red flags. But this is a huge number. We're seeing majority of victims in our practice. And if we take a closer look to breakdown by specialty, 68% of them are in the emergency room. And a lot of us do work in the emergency room during our training. 32% is other providers, which includes psychiatry. So that's OBGYN, PCP, psychiatry, etc. So now we've spoken about the role of the healthcare provider. What do you think the role of psychiatry is in particular when it comes to dealing with victims of human trafficking? Just a question open up for the audience. Anybody?
I would probably think more, probably more afterwards, the trauma that they might have gained from the trafficking. I think that's where we would come in.
Yeah, absolutely. So the trauma is one, and then the second thing is a lot of victims of trafficking are made to use drugs, and a lot of them present to the emergency room either agitated or with altered mental status. Some of them might present with these really unexplained sort of symptoms, and I think we're very equipped with teasing out these nuances. The other thing is these patients already have been through so much trauma in their life. So they're already vulnerable, and we deal with those vulnerable patients to begin with. So early intervention and supportive care can even prevent them from getting into a situation that would encourage them to be trafficked. So I'm just going to pass it over to Archita, who's going to talk a little bit about a case that we saw.
Hi everyone, I'm Archita, also a PGY3 resident at Maimonides Medical Center. Just want to thank EFPT and Charlotte for organizing this. So now we're going to talk about a case that most of us saw in the emergency room. And this is one of the cases that sparked this interest and got us talking and got us into this project. So this is a patient who's a 34-year-old female. She was Mandarin speaking with no known past medical or past psychiatric history. So when she came in, the note said that she was found by security on the streets nearby the hospital, yelling and throwing things. The patient had a knife, gasoline, and lighters in her possession. And when she came in, the patient stated, "I want to kill the people who stole my money." So does anything here sound odd to you or stand out compared to other patients that come to the ER?
I think she's probably a bit more aggressive or dangerous as your average ER patient. And I would wonder if she's paranoid, psychotic.
Right, yeah, exactly. It's pretty odd that she came in with lighters and these things to defend herself, and yeah, is claiming that people stole her belongings. So yeah, she does. She definitely sounds paranoid too. So per the history of presenting illness, the patient said that she wants to kill the person who tricked her, who happens to be the director of our hospital. She was tricked into coming to the US, was forced to work in a massage parlor without pay, that she's the only daughter of the Chinese president, and said that she was drugged with morphine before she was brought here. She also admits to crystal meth use. So what do you guys think about this slide?
To be honest, I agree with Charlotte. It sounds so far-fetched that you would have never thought any of it was true. So you'd have definitely thought she either has a psychotic illness, paranoid, and the fact that she's using drugs and admitting to it doesn't help her case, I think.
Mm-hmm. Yeah, exactly. And especially in the location we are at our hospital, there's a lot of massage parlors, and there's also the marginalized population. So just hearing that is one of the signs that make us feel a little worried. Also, she's a bit grandiose. She thinks she's the only daughter of the Chinese president, and it sounds like she was tricked and she was uh, forced to be intoxicated when she was brought here. Can we go to the next slide? Okay. So she was pretty aggressive when she came here. She was trying to attack the nurse and the mental health worker, so she required intramuscular injections to help with the agitation. She said that she doesn't want to talk to a doctor and only wants to talk to the police. Symptoms that we thought as well, like all of you, that the symptoms were suggestive of psychosis. She was paranoid. She had disorganized behavior, some manic elements like the rapid pressured speech. She had an intense affect. We didn't know if this was due to psychosis or due to substance use, because she admitted to substance use with us. So we held her overnight. And the labs were significant for positive UTOX for amphetamines. So usually in our hospital and most hospitals in the US, in the ER, when we have such a situation, we can hold them overnight and reevaluate them the next day in the morning or whenever they've cleared up. What are your thoughts on this, and is this how it works there as well? In the Europe? Yeah.
Pretty much, yeah.
Okay. Sounds good. So I'm
just want to make people aware that you are muted unless you unmute yourself. So in case anyone was trying to speak, don't forget to unmute yourself.
So in Malta, we're actually fighting to get this holding bay. We usually actually admit them in the medical wards if they have a medical cause like alcohol intoxication or substance use. But if it's clearly psychiatric with nothing else, we admit them immediately to the psychiatric hospital.
I see. Okay, yeah, I think we do that. We work similarly, but yeah, I guess with this patient, we had no history and no collateral to get any other extra information. So we decided to buy some time before we make that decision. So when she was reevaluated the next day, the patient stated that she had been brought in by the police for a temper tantrum, but did not give any other details. She stated that she uses ice, which is a colloquial term for crystal methamphetamine, and said that she's been using it continuously. Regarding the lighters, gasoline, and hairspray in her belongings, she said that she has been homeless and she didn't have any other place to store her belongings. She denied any history of any suicide attempts, admitted to some history of violence in the past, and also reported history of sexual abuse. She has history of inpatient admissions at Flushing Hospital and Bellevue. So Flushing Hospital is it's a hospital that's located in another borough called Queens. And Bellevue is mostly a forensic hospital in New York. And both of these admissions were secondary to substance use, and she denied any symptoms of withdrawal. So what is everybody thinking so far? Anything here sounding abnormal?
Well, I would be somewhat alarmed or triggered by a history of forensic admission.
Yeah.
Ring an alarm bell in my head.
Yeah. And her current presentation seems like she might have presented similarly in the past too because of the substance use. And it seems like she's pretty guarded with the medical personnel, and she came to a hospital but wants to talk to the cops and a forensic hospital being involved. Yeah. So on repeat mental status exam, it was significant for some psychomotor agitation. She was hungrily gobbling food and juice during the interview. Her speech was rapid. She complained of feeling a little feeling tired. Her affect was stable. She denied any psychosis symptoms, was not suicidal or homicidal. She denied any problems, denied the need for treatment. Her judgment was mildly impaired and impulse was tenuous. So on repeat assessment, it seemed like her symptoms were consistent with substance use, which was similar to her previous presentations. She denied any acute psychiatric illness. She refused Bridge Back to Life. So Bridge Back to Life is a substance use referral system that we use in the hospital, and it includes people who also have history of previous substance use who have now been sober and are helping other people with their substance use. So she refused that, and she refused referrals to rehab or detox. We also gave her a shelter referral, but she refused that as well. So she was discharged. So this patient, in the next slide, she comes back again. And in the second visit, which was a few months after, the triage note said we were called to a place of business and they wanted her removed. Someone there told us that she didn't feel well, but we didn't know what was wrong. So police were there to help us take her in. What is everybody thinking so far with the first visit and the second visit?
Can I ask what happened to her after discharge from the first visit? Was she discharged to the street or?
Yeah, so we gave her a referral to a shelter so we could have arranged some transport to get her to the shelter as well, but she refused them and she wanted to leave. And at that point, there was nothing for us to hold her in the hospital against her will. So she was discharged. Yeah.
Yeah.
So in the second visit, she comes kind of similarly. She comes against her will. The police brings her in. She's at this place of business. So when we move on to the next slide. So this time she was grandiose and tangential, said that somebody was trying to kill her and someone called the police, stated that she was sent to the hospital because a woman at the parlor had some relationship with her husband and that was because of her. She said that she cannot go back to China. I am the person who has the bone of dragon. So the bone of dragon in China means somebody who can own a lot of land. She said, I became God since I was 16 years old. I changed my face twice and I was so beautiful thanks to the United States, and mentioned that she saw God. She endorsed difficulty sleeping and poor appetite, but could not elaborate further, felt her life was meaningless and that she's been thinking about death for a long time. She tried to cut her wrist and overdose in the past, but was not able to give more details. She mentioned HIV, but refused to clarify and was offered testing, which she refused. also admits again to using ice, which is crystal meth, 2 days ago. And so again, we thought this is probably substance use. We need to figure out if this is substance-induced psychosis versus paranoia or primary psychotic disorder. So we held her for reevaluation. What does everybody think about this? And would you have managed this differently? I mean, if there was no option to hold, sounds like this might have been a good idea to admit her at this visit. What is everybody thinking? It sounds like again, she's coming paranoid and she is also grandiose at the same time. But somehow, again, we get the vibe that she is being forced to do something and something's happening to her against her will. So we held her, and on reevaluation the next day, she was more coherent in speech. Her thoughts were linear and goal directed. She still couldn't tell us why she ended up in the hospital, and she said that she forgets. She said she wants to go back to China, but still again would like to return back to the massage parlor and continue working there. She denied mood and psychosis symptoms. So again, this time she accepted substance use referral, so we gave her the information and she asked to be discharged. So unfortunately, this patient is one of them that got away. But these, now in hindsight, reviewing her records and looking at her presentation twice, it seems like this patient might have been a victim of trafficking or been involved. Yeah, been a victim of trafficking. A lot of these traffickers, they kind of get these patients hooked onto substances, so they rely on them to get the substance, and that makes them stuck in that position as well. So when we go to the next slide, these are some identifying signs or red flags for human trafficking. So this, I know this slide is a little bit crowded, but it's pretty useful to see what are the identifying signs. So for both adults and children in the US and also in Europe, we are mandatory, we have to report. We're mandatory reporters for any kind of abuse, including trafficking for children. Things that we could keep an eye on for both adults and children are multiple injuries of different stages of healing that don't make sense. Tattoos or branding. A lot of traffickers can brand patients with tattoos. They could have barcodes, or they could have some kind of saying with their name or with the name of the gang or the name of the trafficker. Being dressed not for the weather. So you could see somebody in the summer wearing like full on like winter coats and heavy clothing just to cover their bruises, cover their tattoos. Or somebody much younger dressing more maturely, or having like a child having things like hotel cards or lots of money that is not usually seen for their age. Also coming with these vague symptoms like dizziness, headache, myalgia, young children having multiple abortions, or even adults having multiple abortions, frequent abortions, erratic schedule. These are usually things that we should look out for and assess for trafficking. How about, is there anything else that you guys think that's not been mentioned here, or that you've seen in your ER or in your hospital that has made you suspect for trafficking? Yeah, I think this is pretty detailed about things to look out for. Let's move on to the next slide. Okay, I'm gonna give it over to Rachel.
Okay, so just want to highlight a few details about sex and labor trafficking and the different industries that can be involved. So we already know what sex trafficking is and what the red flags are to identify them. But there are a few things that really stand out when it comes to sex trafficking. Like, for example, you might have a person coming into the ED with a more controlling or dominating partner, much older than them. That could be a red flag. They could frequently refer to the person that they're with as their manager or their boss in some way. A lot of these people who are trafficked, their identification documents are taken away from them. So if you ask them about that, they might just say it's with my manager or with this controlling person they're with. Some industries that are involved in sex trafficking, we already know a lot of, there's a lot of prostitution that's part of sex trafficking. But in addition to that, there's pornography, personal sexual servitude, a lot of strip clubs. They have these illicit massage businesses, which they're actually not even that hidden. In our neighborhood, there are a bunch of places that say that they offer massages, but it's well known that it's more than just a massage. And then we move on to labor trafficking. Again, we know what it is, but just to highlight how we encounter it on a day-to-day basis. So I'm just going to ask you guys a couple of questions. You don't have to answer it. You can just keep a mental note of it. How many of you have traveled across international borders with a complete stranger? How many of you have gone to your local grocery store or supermarket to buy fruits and vegetables or other produce? How many of you have been at a street light and agreed for somebody to come and wash your window or wash your car? How many of you have gone to nail salons or parlors? How many of you have employed people to come work in your apartment or even in your office? Okay, so usually when we do this in person, we ask people to raise their hands or ask somebody to step in front. And most of the time, at least 80 or 90% of people would have raised their hands for at least one thing. So it just kind of underscores that we're involved in labor trafficking in some way. And the way our society is built, it's really hard to completely avoid everything, but just so that we're aware that, the produce or the vegetables that we're getting from there's probably some sort of labor trafficking involved while they're collecting these things. So if you're really interested to know how much you've contributed to labor trafficking, this is a website. It's called slavery.footprint.org. And they ask you a bunch of questions like your age, your location, and just basic questions about your day-to-day life. So I did it, and this is what I got as my result. And I mean, I'm a resident. I barely do anything, and I have 35 quote unquote slaves, and it's such a shocking number to see. And I think this is one of the things that really blew my mind. So if you guys are interested, that's a very it's a dystopian but interesting website to check out. So keeping all this in mind, we saw that we spoke about the patient that we kind of missed, and that got us thinking, how can we better identify these patients? We have a list of red flags, but it's all kind of vague, and it's really not enough to just have a list of red flags and identify a patient based on that. So we wanted to create a screening tool, and in all our research and reading, we found different screening tools, but none of them were validated. They're all invalidated screening tools. And I think a part of the reason is that human trafficking looks so different in different parts of the world and in different parts of the country. So we did a literature review. We found about 80,000 articles, and we kind of took the common questions from each to formulate our own screening tool. This is, again, a busy slide, but I just want to highlight the common questions that we found in each screening tool. So basically, if you want to screen for trafficking, there are 5 different areas that you can really touch upon while you're doing your psychosocial assessment. So one is freedom of choice. The second thing is living conditions. The third thing is identification. The fourth is forced to work or have sex or traded sex. And the fifth one is safety. And a lot of these questions we kind of touch upon in our psychosocial assessments anyway. But if you're talking to a patient and your brain is switching on the red flag that they might be trafficked, you may want to explore some of these areas a little more in detail. So we saw that there were these 5 major categories, and then we just took one question from each that we thought we'd include in our psychosocial assessment, and we came up with a short version of the questionnaire and a long version. So the short question, the goal is basically for somebody working in the ER, like an EM doctor, to kind of administer in a very quick fashion, just for screening. Like, these are the questions, like, have you been restricted? Do you have permission to eat or sleep? Access to identification? Forced to engage in unwanted work or sex? Or have you been physically harmed or threatened? The longer version is something that we intended for psychiatrists and psychiatry residents to include in their assessment. So it's a little more, so if a patient answers yes for any of them, then you kind of explore it further with other questions. Okay, I'll move on to Arch.
So trauma, abuse, and exploitation. In Europe, around 63.6% of people in Europe have experienced at least one potential traumatic event. 1 in 3 rape victims get a diagnosis of PTSD, and 1 in 2 victims of sexual or physical assault get that. Out of that, 10% of women receive the diagnosis of PTSD, whereas only 5% of men receive this diagnosis, per a statistic given by UNGIFT, which is the United Nations Global Initiative to fight human trafficking. So there's a score called the ACEs score, which is an adverse childhood experience score, which involves these 3 different types of trauma, abuse, neglect, and household dysfunction. And it is a 10-question questionnaire which people answer, and it only involves trauma under the age of 18. And the lower the score, the better the outcome, the higher the score, the worse the outcome. So when they did it, most victims of human trafficking have an ACE score of 7 to 10, which is really high, and 10 involves like every single type of trauma on the score under the age of 18. So as the number increases, so does the risk of outcomes. This can affect your brain, cause traumatic brain injury, some mental health, maternal health, infectious diseases, chronic diseases, risky behavior, and also opportunities and overall quality of life. The early adversity causes lasting impacts. So trauma-informed approach. This involves the 4 R's: realizing, recognizing, responding, and resisting re-traumatization. Realizing is to identify the impact, the widespread impact of trauma, and how the high statistics and how important this is, and potential paths for recovery. Recognizing is identifying the red flag signs, recognizing the signs of trauma, and also acknowledging that not all people are ready to talk about their trauma, even if we can see it, and not ready to take any action about it all the time. Responding is by doing trauma-informed care, trying to avoid force as much as possible, trying to avoid IMs and restraints as much as possible, and involving legislature and making policies into the hospital, like which we're trying to implement in ours, and which has been implemented in a lot of hospitals in the Europe. And also to recognize that patients are coming out of their comfort zone into a hospital. They're being forced to change into a hospital gown, being forced to talk about their personal and private information to a complete stranger. And people in the medical team are also doing invasive examinations on them to help them, but it is traumatic for the patient, and it is uncomfortable for the patient. And also it is very important to actively resist re-traumatization, avoid going into details with the patient, even if they're ready to talk about it in the emergency room, because at that point, you just want to figure out how to help them after you identify that they have been traumatized or have gone through trafficking. So this is the trauma-informed approach. Also working with interpreters. It's always important to use an interpreter when you're speaking with a patient that you're not fluent with the language. And it's also important to use a live interpreter as much as possible, talk to the patient alone, give them as much privacy as possible. A few of us attended a conference. Rachel was a part of that conference, and in that, two doctors had mentioned that there had been a few refugees from a small population, and the traffickers had infiltrated the interpreter network. So this is something that we should be careful of. And if a patient's ever uncomfortable with a particular interpreter, we should stop right away. Go ahead.
Okay, yeah. So keeping all this in mind, with the trauma-informed approach, the prevalence of human trafficking, and what we can do, we kind of implemented a protocol in our hospital. It so happened that the Department of Health had also mandated that most hospitals have a protocol in place. And so we decided to have a protocol, but involve psychiatry in some way. So basically, this is what it looks like. So a patient comes into the ER, they're identified as a possible victim of human trafficking by the emergency medicine physician. So they administer the short screening tool. Then they talk to the patient and assess if the patient is willing to get help, they're willing to get out of their situation. If they are, then they place a psychiatry consult. So at that time, the psychiatrist on call goes and talks to the patient and assesses their situation, whether they're being trafficked, and if there are other mental health needs that can be met, like substance use referrals or treatment of any acute depressive, manic, psychotic symptoms. If there's nothing acute psychiatrically and they don't require an inpatient admission, then the goal is to connect them with resources. So after psychiatry assesses them, we call social work, who's well equipped with all the legislations, the visa status, shelter systems and everything. And then they provide them resources that they can get connected with. If the patient is feeling safe and wants to press charges, then we also call NYPD or whatever local police system. And if the patient wants to get further resources, there's a National Human Trafficking Resource Center hotline that we call, or we ask the patient to call. And we've made these tiny business cards with the trafficking hotline on it that we give to the patient that they can hide in their pockets. And we've changed the number. So instead of 888, we've started it with 000, so that if the patient's trafficker finds it, and even if they Google it, they can't find out what exactly that number is for. And we tell the patient that we've changed the 3 zeros in front should be substituted by 3 8s. So while researching for this presentation, we came across this referral mechanism model that they have in France, which is very similar to our protocol, but it's a lot more extensive, and it just kind of helps victims get connected with resources in a more comprehensive way. So it's similar, like they identify the victim, and then they kind of refer them through the national referral mechanism. And then through that, they're connected with lawyers and social workers to see if they want to remain in the country that they've been trafficked to or go back to their home country. And they kind of organize everything, like the travel back to their country or acculturation into the country that they've been brought into. And then after they figure out the logistics of what the patient wants to do, they reintegrate them with using this comprehensive system of like health, education, professional opportunities, family support, etc. So we don't have a system like this in the US. So this was actually really interesting to read about and to see how well they've made this protocol. And yeah, if you guys are interested, you should definitely check it out. It's written very comprehensively on the website. It's called the National Referral Mechanism for Trafficking.
So these are a few resources that I found while looking for your resources available in Europe. This is a really good website. The first website gives all the hotline numbers for the different countries in Europe that we can use as medical personnel when we suspect patients for trafficking. This is the first page, data collection on trafficking of human beings in the EU. The second link gives a different legislature for the different types for the different countries in Europe, and it also gives the different services available for the victims, including for children. In Europe, for children who are not just victims, but even those at risk of being trafficked also get a lot of these services. So the National Human Trafficking Hotline is the trafficking hotline that's available in the US, which victims can call or text or go online for. This is a similar kind of hotline for the Europe, and Modern Slavery Helpline is the helpline for UK, which also uses the same text call or website format. So you can, as Rachel had mentioned, you could change the digits. So like the National Trafficking Hotline, you can change the 8s to 0s. Also, it's very important for you to not give it in a paper with the discharge papers, because that could get into the hands of the trafficker. You could give it in a small post-it, or write just the numbers randomly in a tiny piece of paper that they could hide in their sock or hide in their belongings. You could also leave a card in the bathrooms of the hospital, where people who are not ready to talk about it can still see it and get some help. Love 146, Coalition, COAST, and AIM are all international non-governmental organizations to help with trafficking. AIM stands for Agape International Missions, and it was founded in Cambodia. And it's used to prevent humanitarian aid and to end sexual slavery in Cambodia. For the UNICEF, there are more than 1 million children who are being forced into sexual trade, and many of them come from Cambodia. In 2006, AIM also opened a safe haven for rescued girls to heal. The Love 146 is focused on children to end child trafficking, and so is Save the Children. Council of Europe had this conference in 2008, and they started this organization called Greta, which is Group of Experts on Trafficking Against a group of experts on action against trafficking of human beings. And Greta is basically an organization in Europe that goes and visits countries and makes sure that legislation is being followed, and they are actually giving the resources that they're supposed to give for these victims. Yes, and UNGIFT is a global initiative to fight human trafficking.
Okay.
So this is the World Day Against Trafficking of Humans. This is July 30th, something that we should celebrate. And this is our team.
Yeah, and this is our team. So we're like a group of residents. It's a resident-run team, and we have one mentor. But we really started at a very grassroots level when we were first-year residents, just reading about trafficking and trying to implement things. And the way we went about it is by talking to the people involved in emergency medicine, getting in touch with the social work team in the hospital, just reading different research papers and seeing the authors and contacting them to find out more about protocols in their hospital. So if you guys are interested in this really important and grave topic, I really encourage you to try to network with people within your hospital itself to set something up.
Yeah, and there might be something even in your area. Like we recently heard about the Brooklyn Human Trafficking Task Force, and are trying to collaborate with them to just get more resources, anything available to give our patients.
Yeah, and we'd like to open it up to questions or comments.
Thank you so much for that presentation. Very, very interesting and very impressive as well, I must say. On one hand, because of all the resources that already are available that I personally wasn't very aware of. But yeah, I'm even more amazed by your team, by, you know, like you said, you started recognizing what happened and you went from there, and to see what's in place now, it's very, very impressive. And I was just wondering a bit, when you first started getting into this topic, how much of what you presented today was already available, and what did you guys find was, you know, not there yet, and how did you fill that need, that void?
So I think a lot of the resources were already established, but it's just that we had no awareness at all. And we started by just reading research papers and getting in touch with the authors of those papers. And because of that, we actually attended this global human trafficking conference, and that's where we really connected with global leaders and authorities on this topic and learned a lot more about the process and what we can do as healthcare providers. So I think the conference was really where we accumulated most of our knowledge and ways by which we can establish a protocol in the hospital.
Yeah, and we also met with a victim that had gone through all of this and got some advice from her and from the New York Police Department about things that what they're ready to hear and if they would even like us as psychiatrists to be involved.
And she responded positively, or?
Yeah, so actually when we went for the conference, it wasn't just psychiatrists, it was doctors from all different specialties and even other people like law enforcement and people from religious backgrounds and stuff. And we presented our protocol there that we'd call psychiatry when we suspect a victim. And almost everyone was like, that's a really bad idea because these patients are already stigmatized. You're adding to the stigma by calling the shrink. And so we felt quite disappointed. But we spoke to a bunch of survivors of trafficking, and they said that when they were in that situation, all they really wanted to do was talk. And if someone was willing to listen to them, they would have spoken. And they thought calling psychiatry was a really good idea because, you know, in an ER setting, people are so busy that they're really not going to talk to a patient about their situation. They're just going to assess medical needs immediately and discharge them. So we got a really positive response from survivors, and we thought that's the input we should really take.
That's great. Well, I mean, they're lucky that you guys got involved, that's for sure. Anyone wants to ask a question, they can.
Yeah, can I? Fantastic presentation. Many thanks. And I think at least the first question I can think about is, what are the barriers from the side of the providers that you can identify? For instance, many providers can be afraid of kind of being involved and also afraid about possible retaliations, not only for them, but also for the victims. And yeah, what other kind of barriers you can think about?
I think there definitely are, especially at the beginning and even now. We hesitate or we're reluctant to talk to patients when they're not ready to talk about it, or when even in the ER, we see a lot of times that we have an overbearing caregiver who will not leave their side, who will just not give them their privacy. Even getting privacy in a medical ER is difficult. So that means we would have to try to get them back to a psychiatric ER, but that would also involve them to be held against their will, to change into our hospital gown. And do we really want to put them through that? We're afraid we'd cause more damage than good. These are things that definitely are barriers. Also, at the beginning, we didn't know about these resources. We started with giving everybody the hotline because that's what we first found out, and then slowly we started finding other resources for shelter and that were available.
I think another huge barrier is a cultural barrier, because a lot of times our patients are not from the same cultural background as us, and there might be a general mistrust because of whatever reason. Maybe they're undocumented immigrants who don't want to share their situation. Maybe it's the migrational trauma of being from a different country and just not trusting people who seem like they're from this country. So I think that too.
Any other questions? You can either unmute yourself or type in the chat.
Hello. Would it be very difficult to establish the abuse in an acute psychotic patient or in acute psychosis in general?
Yeah, absolutely. It's really hard to establish rapport and assess for abuse and trauma in an actively psychotic patient, which is why I think we'd be more helpful in giving them that immediate stabilization in a psychiatric unit where they get the treatment that they really need for their psychosis. And maybe once they clear up, if you can further build that rapport with them to give them whatever resource they might need.
I had another question about the case that you presented. Did you see the patient yourself?
Yeah.
Yeah.
Okay. Because I'm wondering, obviously this is all in hindsight, but it sounded like she was very reluctant for any type of care. And I wonder if if she was a victim of human trafficking, would you have expected her to maybe be wanting more care, to find a place to talk about something, or just wondering why she was so reluctant maybe?
I think a lot of these patients, they are afraid of getting caught by the trafficker. Even another patient that I've had on the floor is that she was afraid of even leaving the hospital because she was afraid that this trafficker is going to find out where she is and then just follow her or cause harm to not just her but her family if she discloses this information. So that is definitely something that we need to keep in mind. Also, Rachel, you were going to say something.
No, I think I think you hit the nail on the head. And yeah, I think with her again, the language barrier I think was huge because she was Mandarin speaking. We don't know what got lost in translation even. So I think that too contributed to it. And I also wanted to, I forgot to mention when we were talking about the barriers to assessing victims, we did a survey before we trained the residents in our hospital for human trafficking. And in that survey, we asked them about their comfort if they had to deal with a victim of human trafficking. And 100% of them, like all of them, said that they were either not comfortable or only somewhat comfortable. There was nobody who said that they'd be comfortable talking to a patient who's screened positive as a victim of trafficking.
That's interesting, but also recognizable, I think. I think if I asked the same question here in Belgium, I'd probably get a very similar answer. And actually, that's a big question to everyone who's attending, but is there anywhere else where, another country where anyone has this sort of flow chart, this screening tool as was just presented? Because I don't think I've worked in ER and no one's ever told me about it. So I'm wondering about other countries.
Yeah, I'm also wondering if you, Charlotte, and others from Western Europe can talk, because I guess there's a difference in the management of this, also from a kind of social perspective, when you have a public healthcare and welfare system like in Western Europe, and when you have a different system like in the US, right? But I don't know, Charlotte, if you kind of have some thoughts on that.
Well, my first thought would be, do you mean when we talk about healthcare system, from what I know about, it's a bit more accessible here in Europe than it is in the US?
Yeah, and I would say usually the social services would be kind of more on top of that and following up kind of more closely the case. But
you think and hope that, but I can't say I'm too hopeful or positive about it either. Just from, I was talking to Rachel and Artida before, especially with war going on in the Middle East, we've had a lot of trafficking here in Belgium, and there's some pretty sad stories there, and I think the government is failing on a lot of levels. And when I see how me or my colleagues, I think in ER, are not educated on this, I think we still have a lot to learn, even though our social system probably is a bit more adapted to it and a bit more open to it. I still think there's, a lot to learn, and a lot of people are being missed, because you hear some very sad cases of people dying while being trafficked to England, for example. Or, yeah. I see Dr. Behar wanted to say something.
Hello, do you hear?
Yeah.
We can hear you.
Yes, kind regards, dear colleagues from Kosovo. I have opinion for trafficking human. The intervention aims to increase preventive measures for people at risk of trafficking and to support those who have survived this modern slavery, but defending their rights while providing a range of priority services as well as assistance for socio-economic reintegration, and aims for more interaction with children's parents, young people, and frontline employees. Trafficking in human beings is not just a crime and the most unacceptable form of human rights violations. It leaves deep traces physically, psychologically, and emotionally on all those directly or indirectly affected. Unfortunately, children are the ones who suffer the most from the consequences of this crime. We have to act now and act together with those who are forced or capable and who have the will to end this phenomenon. We have a coalition of national and international partners. We have motivated actors between both authorities and local organization, and we have the supports of the government to make a difference for those people who have escaped the horrors of trafficking. The slavery program and the provision of support for, one moment.
Sorry, continue.
Individuals to fall into the hands of criminals who aim to exploit the weakest. Modern slavery is a hidden and unacceptable crime that can happen anywhere, preying on those who are the most fragile in society, as well as working child health professionals, social workers. We will raise awareness and oppose all forms exploitation by protecting the human rights and dignity, especially of children's. This initiative is anti-trafficking, which includes also the OSCE presence in Kosovo, Albania. Teredes Homes is organization for the Save Children's, as well as 3 local organizations, Vatra, Division, and different. Thank you very much.
Thank you. It's good to hear there are some organizations.
Yes, because I am child and adolescent psychiatrist, I am focused more for children's.
Of course, yeah. Thank you. I see Jabril had raised his hand as well.
What?
Yeah, I raised my hand, and I'm Dr. Jibril. I'm a psychiatrist based in Ethiopia now. I'm interested in human rights, cultural psychiatry, and issues related to global mental health. I'm interested to know how a psychiatry resident or a illegal psychiatrist can recognize the effects of human trafficking among our patients, because this is a global issue, not only relating to children or women, it is affecting everybody. Like in the European Union, most of the people who come on the seaboat are victims actually of human trafficking, like the people who come from Libya or Greece. they have to pay a lot of money to be trafficked from their countries of origin to the shores of Europe. Then how we can identify them all in the countries of origin and also to the countries of destination. Thank you very much.
Yeah, thank you for that question. So it is a challenge to identify these victims, but a lot of studies and a lot of talks with survivors themselves have said that they've encountered doctors or healthcare professionals while they were being trafficked. And a lot of times it is essential for them to visit a doctor because they have unexplained injuries. In sex trafficking, they may suffer from STIs or unwanted pregnancies. In labor trafficking, it's all the long hours that cause wear and tear of so many different parts of their body. So it is likely that they would encounter a doctor, and if it's in the emergency room, then it's about 68% of them that actually go to the emergency room. So that's where a psychiatrist can be called to the emergency room if they feel like there's something about this patient that would benefit from further intervention from a mental health standpoint.
Thank you. Does that answer your question, Jabil? Sorry.
It answered my question because this is something that we're going to see in our practice as practicing physicians, and we might miss them, just diagnosed with depression or PTSD or brief psychosis and so on and so forth, without looking at the human trafficking nature, which is a psychosocial stressor for this patient in their formulation, and we might miss that easily if we don't take the history, for example, more deeply. And also it affects our management, I think. That's why I raised this question as practicing clinician.
Thank you. Alma, you'd raise your hand as well? Sorry, you need to unmute yourself first, I think. Or... I can't hear you. Don't know if other people can. No. Okay, she's getting headphones.
Something wrong with your mic.
Magical solution. In worst case, you can type it in the chat.
Can you hear me now?
Yes.
Okay. Hi, everyone. I am a second-year adult psychiatrist trainee from Romania, very close to the western border of Romania. And I want to tell you about two things. One, in terms of resources, I have encountered a patient this year recently, which I suspected of being trafficked. And he was a Pakistani citizen with residency in Germany. And somehow he was, he alleged to be brought to Romania by someone he'd known, and he was withholded for labor work. And he arrived to the psychiatry ward brought by emergency, because he was suspected of suicidal risk. Somehow from the parking lot of a mall, people thought he was going to jump. It was a 50-ish man, and he was quite disoriented, and we had a huge linguistic barrier because he only, besides his native language, he only spoke German, and our German, or at least the doctor who was on call didn't speak very much German, but he was admitted, and in the next days we managed to get some of our colleagues who were more fluent in German. And one thing which actually helped us was that we addressed to the embassy, the Pakistani embassy, who helped us to contact his family, and actually one of his relatives came from Germany to bring him back to Germany. But it was quite difficult even with the, so in Romania, we don't really have translators, and anyone with this quality job. We have social workers, but in terms of languages, we are not doing very well, other than maybe English. or French or a bit of German. And it was quite interesting because even the Pakistani embassy employees told us that his mental status isn't really clear, that they don't really understand what he's speaking. So we suspected some, so he was quite disoriented and paranoid and had some paranoid ideas, which we couldn't really link. And we suspected some onset of dementia. It was a very interesting case. I proposed to my coordinator to address also local human trafficking organizations or the official institution for this, but my request was declined because I was told we should not mix up ourselves because the family will take care of this. I wasn't really comfortable with this decision. And it's by chance I suspected it, or I tended to believe the patient because I was in another context sensibilized to the human trafficking topic. This was one idea. And in terms of Eastern Europe and human trafficking, besides of the famous sex work industry from Romania and other Western countries, there's also a new one, which lately we started to hear more about in even like in some investigatory journalism pieces about labor trafficking for middle-aged or elderly, middle-aged, let's say, women to take care of Western European elderly, like home nursing or something like that. And that's quite, and there are so many agencies which are quite shaky about their transparency. And that's quite a big issue lately, because we had a few patients who got through this system and actually arrived back home quite traumatized, and they are now in psychiatric treatment. So that's also maybe a less known topic about Western Europe.
It sounds like you did a lot for the patient. Thank you for sharing that. It sounds like you and your medical team really did a lot to try and give as much tailored healthcare as possible for the patient. Unfortunately, with interpreters, we have the same issue here at times when it's a language that's not available here, and so much goes lost in translation. And their definite depression and trauma, especially long-standing depression, can cause pseudo-dementia and could have definitely affected his cognitive status. But at least I'm glad that he was able to somehow get in touch with some of his family. With resources, I guess even us, we try to use the hotline as much as possible to give that to our patients. At least they would be able to direct them to different places where in the area which are available for them. And a lot of these resources are not as freely available even on the internet to protect the patients themselves, because traffickers could get their hands on them. But yeah, I guess the resources are most available through the hotline. That's the easiest way to get in touch with them.
Thank you. And thank you, Alma, for also highlighting that aspect, because when we were talking about Europe before, I think there is also a lot of labor trafficking from Eastern to Western Europe. And with the EU and the free movement of people and of labor, it can be under-recognized. So thank you for highlighting that, Alma. We're well past 7 now, so I'd say if there are any burning questions, my experience with Rachel and Archita has been that they're very passionate about this project and very happy to share their experiences with anyone who wants to learn about it. Like I said, I'm very, very impressed by your work, and I do really want to look into how we in Europe can learn from that and how EFPT can maybe benefit from your knowledge and our collaboration. So thank you so much for presenting to us today, for being with EFPT. Very happy to expand our family. And yeah, just a big thank you and well done for your work.
Thank you, Charlotte. Thank you so much for giving us the opportunity. It's always a pleasure, and yeah, really grateful to keep spreading the word.
Yeah, like what Rachel said, thank you so much for having us here and letting us talk about this. And yeah, it's been a great experience.
Thank you. Victor just mentioned a very important point that he always thinks of and I don't. A group picture. I'm not good with these things, but yeah, people want to turn on their cameras. Let's see, I think I can get most people on screen. Time, fix your hair, fix your makeup.
Thank you very much, Dr. Charlotte.
Victor's leave. I don't know what he's doing. He's getting his makeup, I think, but. Okay, I'm gonna try this new computer. Everyone smile. Let's take one more to be sure. There we go. I'm gonna take one with my camera as well. There we go. Thank you all for being here tonight, and have a good evening.
Thank you.
Thank you.
Thank you. Bye.
Thank you all.
Best wish.
Thank you.
Hey, thanks, Rachel and Richella.
All right,
Thank
good
you.
to see you, Victor, always. Oh.